my disclosures here. Our objectives are really very briefly to understand the controversies surrounding screening and really to focus on how baseline risk assessment can play an important role in prostate cancer screening. And I think that dovetails really nicely with what Dave and Sigrid are going to be talking to you about this morning. We all know that prostate cancer screening, PSA-based prostate cancer screening, has saved lives, but unfortunately, there is a tremendous amount of inefficiency with prostate cancer screening. In the American study, no survival. In the European study, there was a significant survival benefit to prostate cancer screening, but the number needed to screen was so high that the various organizations have come up with varying degrees of confusing recommendations. And I applaud people like Dave for dumbing it down for the masses, you know, simplifying the message. And I think that's a really important thing that we need to do as a community for our primary care physicians, because it's confusing. And this confusion elicits vitriol in us. When we see that survival curve trend upwards, when we see that increased presentation of high-grade disease, we get incredibly frustrated because we know we can detect these men early and save their lives. So this confusion has led to a tremendous decrease in new diagnoses, as Dave alluded to earlier. We went from 250,000 diagnoses in 2012 down to 165,000 this year. That's 75,000 men walking around with prostate cancer who have been stripped about their ability and right to know about their disease. This is a real problem. We need a call to action as a group to really fight against this. In our community alone, we've seen a tremendous increase in presentation of high-grade disease. So I think we're not taking PSA as seriously. I think our biopsy thresholds are going up. And you can see that the median pre-biopsy PSA in our community has gone up from 7 to 8. The rise in proportion of men having PSAs greater than 10 at the time of diagnoses have also gone up. So, as well as men diagnosed with Gleason 8 disease. So it's clear that PSA-based prostate cancer screening saves lives, but is tremendously inefficient. And that PSA, as well as digital rectal examination, may not be the best markers for the average risk patient. So these markers may need some bolstering. They are what they are. I think PSA is an excellent marker, but it just needs to be used properly. So what about this concept of risk-adapted screening? We all know and love the subject, but does it really make sense? Does it work? Well, the only risk factors that we really have are age, family history, and racial origin, which I would argue are all surrogates for genetic predisposition. We do have emerging new biomarkers. One, germline genetic testing, which I'll be talking to you in greater detail about today, but other things like early PSA in life, such as what Dave has introduced into the vernacular, as well as the MSK group. So here, if we look at the PLCO study and we look at men without a family history, you can see that survival curves are essentially overlapping. I need to point out my former fellow, Mike Liss, who's now at UT San Antonio, who did this work. So men with a family history within the PLCO study, however, did enjoy a survival benefit. So you can see the survival curves here on the right, suggesting that risk-adapted screening, at least based on heritable markers, may play an important role in our future screening algorithms. The problem with family history, well, only 7% of the study participants in PLCO were positive for a family history, and that's also a problem with our situation now. With the decreasing number of new diagnoses of prostate cancer, we're going to lose that biomarker, that family history. So what about the role for potential SNPs, or single nucleotide polymorphisms, on prostate cancer screening? Does everybody in the room know what a SNP is? Okay, I'll take that as a resounding yes. No audience response needed for that one. Okay, so these are single nucleotide base pair changes that exist throughout the genome. And in 2007, thanks to some really interesting genome-wide technology, we were able to identify single nucleotide base pairs that were associated with complex disease risk. One of the first diseases that people focused on was prostate cancer. The first single nucleotide polymorphisms include a panel of 5. These were consistently seen in multiple studies. Each of these SNPs were modestly associated with prostate cancer risk. So although interesting, not clinically relevant. Well, coinciding with my time at Wake Forest, together with Jianfeng Xu, we packaged this panel of 5 SNPs, and we were able to publish it in New England Journal because we were able to identify a group of men who were at exceptionally high risk, 10-fold higher risk, which was an interesting proof of principle, but it was only applicable to a very small percentage of the population. Fast forward, 2009, over 30 of these SNPs had been identified, and now we're starting to come up with a test that actually has some interesting performance. So it now includes over 30 of these SNPs. We validated a test including these 30 SNPs in various populations. PLCO, prostate cancer prevention, reduce, thousands of men in 4 biopsy populations, thousands of men from Toronto presenting for prostate biopsy. It's an incredibly interesting marker, and it outperforms all existing biomarkers for men presenting for prostate biopsy, as well as following a negative prostate biopsy. So you can see here in reduce its performance. I mean, it's not great with an AUC of 0.59, but it beats family history, which is really what we're competing against. We are complementary to, but independent of family history. So you can see in the 3 major prostate cancer trials, okay, so that we outperform family history. You can see how family history is a binary marker. It bifurcates your risk. So if you're positive, that means you have a first-degree relative with prostate cancer. It definitely increases your risk of prostate cancer from 24% overall in reduce up to 33%. If you're negative, however, it doesn't really lower your risk. It drops it from 24 to 23. So using the genetic score, you get a spectrum of risk. And you can identify people in the tails who really may benefit from screening and others who may benefit from foregoing screening. We've come up with a potential risk-adapted algorithm based on this spectrum of risk. So when we look at large populations, such as the prostate cancer prevention trial, we looked at a group of men less than 60 in the placebo arm of this trial, really to kind of get the cleanest screening cohort we could. And we looked at the number of screening events over a 7-year period and the number of cancers that were detected. Importantly, in this group, all men underwent a biopsy at year 7, regardless of their prostate cancer status. So you can see that if you screened everyone, there would be 11,000 screening events with 33% of high-grade cancers detected. Whereas if you used the prompt test, we'd cut that in a third and build up the high-grade cancers detected. So it also helps identify those men who would benefit from biopsy. As well, it also helps identify those men at risk for lethal prostate cancer. With 100 men dying of prostate cancer at our place, only 5 tested negative on the prompt test. It works extremely well with PSA less than 1.5. If we looked at those men who are low risk on prompt with PSA less than 1.5, there wasn't a single screen-detected cancer in that cohort.